everyone. Welcome to our live session today. I will be going over a startup presentation to welcome you all and introduce you to our program and various opportunities if you have not previously attended our shadowing sessions. Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources no matter their demographic status, abilities, or location. My name is Lorelai Rodriguez. I am the Chief of HCP at Pre-Health Shadowing. Thank you for attending, and let's get started. So just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen. If you need assistance enabling the transcript, please direct message one of our team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations for how we could improve, you can email us at info@prehealthshadowing.com. Since this is an international program, we want to know where you're Zooming from today. Drop it in the chat. I'm calling from New York City. Awesome. Alrighty. So if you want to stay in the loop, follow us on social media. We are active on Instagram, TikTok, or sign up for our email list on our website to never miss a session. We have some wonderful opportunities for you all as benefits of being part of our program. We have partnered with Kaplan to get our students a 10% discount that can be used on all Kaplan products, as well as free resources such as study guides to help prepare for standardized testing, such as the MCAT, NCLEX, or PCAT. If you fill out a short survey in the chat, we will get you signed up for all of these deals for free. We would also like to draw your attention to another amazing program, Neolith. Neolith is an online mental health platform for students. For pre-health professionals especially, we know the path isn't easy. That's why we have partnered with Neolith to spread the word and offer free access to their services. If you use the link in the chat to sign up for you can sign up using the code PREHEALTH when signing up. Alrighty, Mask for Mask is an amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic, those in homeless communities, healthcare workers without proper PPE, and others who are struggling to stay safe. With our discount code PHS15, we can get you a 15% off your order. If you buy through this method, Pre-Health Shadowing will also get 10% of the proceeds, which is amazing because we are a nonprofit that runs solely off of the support of our community. If you would like to play a bigger role in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be a part of the administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and more. We understand that as a pre-health student, you may not have the time, so we also offer the opportunity to volunteer asynchronously with tasks that can be done at your own time. We would love to have you to be a part of our program and contribute with your unique perspective. If you are a high school student and want to get involved, we have started a program called HTP, High School Training for Pre-Health Shadowing, which allows you to connect to college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through PHS. So I am the Chief of HCP. If you have any questions, you can just email me, hcp@prehealthshadowing.com. And we want to recognize the hard work of all of our students in the program. So if you're interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link dropped in the chat. So if you have any work for our website, this will look great on CVs, applications, resumes, etc. So take advantage of this. Part of our mission at Pre-Health Shadowing is to promote diversity. And in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series of patient experiences, a COVID-19 roundtable, and international student forum. If you have a mentor, professional, or a professional that has inspired you that can contribute to these conversations, please nominate them today using the link in the chat. And we also humbly ask if you could donate to our program. As you know, Pre-Health Shadowing is completely student-run, and we run around the clock to keep this free, especially to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially stable, we request to send this link to someone who you know can continue the support for those who can afford similar opportunities. Throughout the session, we encourage you to drop any questions you have for the speaker in the chat. Our team members will be making note of these to be asked in the latter half of the session. Take good notes. Take good notes, as there will be a short quiz after this session today. And the virtual, you can get a certificate that can certify your virtual shadowing hours. Lastly, we request to turn on your cameras. This is by no means an obligation, as we are respectful of different circumstances, but it does help feel closer together in a time when socially distance is mandatory. We also request that if you could please mute yourself, as this will ensure the professional has the complete and full attention from the audience. I appreciate for you listening. Now, I'd like to welcome our professional, Dr. Barney. Thank you so much for joining us today. You may now share your screen whenever you're ready.
Thank you so much for having me. Okay. Great. Can everyone see my screen okay?
All good.
Okay, wonderful. Okay, so we'll go ahead and get started. My name is Dr. Elise Barney. I'm a nephrologist and a clinical assistant professor, as well as a pre-clerkship block director at the University of Arizona College of Medicine in Phoenix, Arizona. I see a lot of people from different places today, so very, very cool. What I'd like to talk to you about today in our session is just a little bit of background on me and my chosen career as a nephrologist and an academic physician or a physician educator. How I got here to this place that I'm at today, and then I'll take you through some typical cases that I see, some typical patient consult scenarios, and we'll walk through them. And I have some fun questions along the way. Hopefully, we'll make it interactive and fun. So, we'll get started. Okay. So my chosen career, I split my time almost 50-50 between academics as an educator, as I mentioned, at the University of Arizona, and then as a nephrologist and a hospitalist. So I have two specialties. The first main specialty being internal medicine. I'll talk about kind of how you get there, and then a subspecialty of nephrology. So I tend to think of myself as more as a nephrologist, but nephrologists are internists as well. I work as a locum tenens physician or a contractor physician, and what that means for those who aren't familiar is I contract with kind of temp agencies for physicians or healthcare professionals, and they find different jobs and temporary needs in different areas. That usually means quite a bit of traveling, and I travel to mostly rural areas where specialists are a little more harder to come by, and underserved areas, again, where specialists are not in great quantities. So I've been all over the country this past year, a lot of time in Georgia, Montana, Nebraska, rural Arizona, a lot of emergency work during the past year during the pandemic due to the high incidence of kidney failure with COVID-19. So some reports are as high as 70% in critically ill patients that have kidney failure from COVID. So a lot of work for me this past year, a lot of emergency work. Kind of thought of myself as a COVID nephrologist over the last year, even though that's not a real specialty, it's kind of become one for me. And then here in Arizona, I work locally, keeping up with my internal medicine. And what I didn't mention, if you don't know, internal medicine is medicine for adults. And I work as a hospitalist, which is one of the settings you can do in internal medicine. So admitting and caring for patients in medical surgical units with various diagnoses. I work at the Phoenix Indian Medical Center here as well. Okay. So a little bit more about nephrology, my subspecialty. The role is more of a consultant versus a primary care physician or provider. Nephrology, the word nephro comes from Greek nephros, meaning kidneys. And a lot of people in the medical world think of us as sort of the thinkers, more cerebral type people rather than the doers. Some specialties are very procedural driven, obviously surgery, but even within internal medicine, you have specialties like gastroenterology or cardiology where they end up doing quite a bit of procedures. For us, there really aren't too many procedures other than dialysis. And so we're more of the thinkers. The skill set for being a nephrologist is more of an analytical mind, critical thinking comes into play a lot, problem solving, detail oriented. We'll get consulted on cases where you really just kind of comb through large volumes of information in a chart and kind of put like a puzzle, put it all together. So I get a lot of joy out of that and find that to be really fun. So if your brain thinks on that kind of level, nephrology could be a specialty for you. What do we treat? Well, it's kidney disease is the specialty, but also electrolyte disorders, as those are regulated by the kidney, and hypertension, which is blood pressure, is also regulated by the kidney. So all intertwined in my specialty. Management as a nephrologist is focused really on pathophysiology. So again, if you like physiology, if you're that kind of brain, that this could be a good specialty for you. We individualize treatment rather than just relying on like algorithms or clinical guidelines. Some specialties are very driven by that and based off of evidence. Nephrology, like I said, it's more of a thinker specialty. So you kind of have to think your way through each patient and individualize it rather than just following a cookbook or a guideline or an algorithm. So there's a lot of fun in that I get out of it. Clinical time for a nephrologist is split between inpatient, meaning the hospital, office or clinic, and then dialysis centers. So there's really 3 different places where we practice. And that also always kind of keeps it fun and fresh and keeps you from getting bored. So I like this quote that life is what happens when you're making other plans. I put together a collage of the last year as I was thinking about my career and said how it took a little bit of a turn. And it just kind of tells you what you just need to be flexible, and actually you can make your career what you want it to be. So even though I just described a typical nephrologist career, this year threw everybody, I think, for a loop and put a little bit of a wrench in my plans. I had planned to open up my own practice, and that was in the spring when COVID hit. And I just started getting all these calls for help, and I really wanted to help. And so I jumped at the opportunity and just kind of dug in and flew around the country, like I mentioned, going to different hospitals. One in Georgia in particular had a really bad outbreak of COVID and a lot of patients in kidney failure on dialysis. And so I spent a lot of time there helping patients with COVID-19. So this is my past year. Okay, another quote I like is this one. The important thing is to not stop questioning. Curiosity has its own reason for existing. And I want to do a Zoom poll and see if anyone knows who is the author of this quote. So let's go ahead and start the poll. Is the poll going? I'm not seeing it.
I have access to the poll, but we don't have that question, but it has like a background on the student. I can launch that one if you'd like.
Sure.
Yeah.
I put ABCD, so if they can just, yeah.
Okay, that's fine then.
Okay.
Starting to answer
a generic one or okay. I'm seeing the chat, a lot of A's. Okay.
Yeah.
Okay, should we just go with the chat consensus?
Yeah.
Okay, great. Albert Einstein seems to be the consensus here, and that is correct. He's got a lot of great quotes. Okay, so moving along, my path to medicine. Let's talk about that. So why medicine? Had to kind of think back a little bit for this one, although time flies so fast. So this goes back for me as far as high school, and probably many of you as well. And some of you are still in high school or just in college, starting college. So, and people make these decisions at different times, and it's not just one moment usually. For me, it was just sort of a culmination of different experiences, but I went to a Jesuit high school where the motto was men and women for others. And that was kind of drilled into our heads a lot. but I also just personally had this desire to help others. And so medicine was a natural fit for that, natural calling if you're somebody who just has that kind of desire to help. And then I had an accident. I was hit by a car in my sophomore year of high school, and I broke both of my legs. And that just was a very traumatic experience, being a patient and not being able to walk for 6 months, being in a wheelchair for a while, and going through the whole healing process, meeting a lot of great physicians and people in healthcare along the way who helped me recover, full recovery from all of that. And that kind of also made me open my eyes up to the field of medicine and the possibilities of what can you do to help people and heal people. Family influence, probably many of you have as well. I didn't have any physicians in my family, but my mother is a dietitian and a nutritionist and works with patients with diabetes. And she's actually very well respected in her field and has written a lot, and has a camp for diabetes. And she really has a passion for that and for helping patients, and had a lot of phone calls at home from patients after hours. So almost felt like being in a physician family. So that was an influence as well. And then, I did some volunteering. I went out there and verified, is this really what I want to do? What does it look like in the hospital? What does it feel like? How is this going to be? And then just my personality is problem solving. I get a lot of fun with puzzles and figuring things out and challenges. And so if you like a good, career where you get challenged a lot and you're constantly kind of thinking through things, it's a really rewarding career for people who have that desire, that kind of mindset. So how did I get here? Little background on that. I was actually a non-traditional student, French major, and I have a Bachelor of Arts. So it didn't start out with science. Given, all that I just told you, you may think I just, went that route, but I didn't. I actually have a lot of other interests besides science and medicine, even though I love all that. I also love languages. I love traveling. And so I back then, I think things are different now, but back then I was told not to do that. Do not do that. Don't be a French major. How are you going to go to medical school? And I had a lot of naysayers, including advisors at school, that told me not to do that, but I did it anyways. And I have zero regrets about it. I spent 6 months in Paris studying. I had the time of my life there, best memories of my life. And then while I was in college, I did a service trip in January. They called it a winter term service trip to the Philippines, and had an amazing experience there that really solidified it. Yeah, I enjoy languages. I enjoy these other things, but my heart's in medicine, and that's where I want to go. Eventually, I did have to do an extra year of pre-med courses after I graduated at a local college. I went back home to Chicago, which is where I'm from, and did all of my pre-med courses, almost all of them. I think I might have had a couple in before that, but I kind of knocked them all out in 1 year and applied to medical school that year. Along the way, I've been, I did volunteering, I did some work in shadowing other physicians and kind of getting my feet wet a little bit. And then I applied to medical school. This is actually my picture from my interview. And I came out to Arizona here and had my interview, and I loved it here. And actually, I thought I was going to stay in Chicago, but I was waitlisted at a lot of the schools there, and I didn't want to wait. And I loved the feeling here that I got coming to Arizona, and also being a DO was kind of a little bit more well-rounded, at least at the time, of education. So I was admitted to Arizona College of Osteopathic Medicine, which is part of Midwestern University. And so I was accepted, and matriculated. For a year, I had a year gap between applying and starting. And during that year, I actually taught. I was a substitute teacher for grades 5, 6, and 7 in French. And even though it wasn't my minor, I had taken enough Spanish courses along with my French major that I could teach Spanish as well. So that was a really fun year, break in between before starting medical school. Okay, time for another poll. If anyone's, traveled around, you might recognize this. Let's see in the poll. Do we have the poll for this question, or we could do the chat if not?
Chat.
Okay, all right, we'll do the chat here. See if anyone knows where this is. Beautiful place if you haven't been. I see A, I see C, and I see a couple of B's, and D, I kind of spread out in D. A, okay. All right, I'm going to tell you guys, it's kind of across the board here, I think. Looks like a mix. But this is actually Australia. This is like called the Heart Island, Little Heart Island. This is not inhabited, but this is all coral reefs, Great Barrier Reef. One of the most amazing things I've seen in my life, if you can see it, especially given the threats with climate change. This was back in 2017, and I think that we've lost some of that coral, but absolutely stunning, phenomenal place if you can go. Okay, so what next? So got into medical school 4 years later, I was a doctor of osteopathic medicine. This, I believe, has changed, but for certain states, DOs were required to do a traditional DO rotating internship, which was just sort of kind of a mix of different things in medicine, different rotations. And Florida was one of them, and a couple other states. I believe now it's no longer necessary, but I did decide to do that internship, just I guess in case I ever practiced in one of those states. So not every DO was doing it at the time. It was optional. But I did do an internship, and I was in Florida for that. And then I did a residency in internal medicine for 3 years. Followed by a chief resident or junior faculty for 1 year. And so that I was no longer a resident, but I was overseeing the residents and doing a lot of teaching during that year. And so that's something that you have to apply for and get chosen by the program, by the residency program, to have that role as more of a teacher and kind of organizing the residents, leadership role. So that was a great experience. And then after that, I did my fellowship in nephrology in California at UCLA Olive View, and that is a 2-year fellowship. I put the dog in the hoops here because it feels like a lot of hoops, and it is. So if you're going to go into medicine, just be prepared. It's a long road, but gosh, it sure does fly by, as I look back and talk to you guys today and go kind of way back and where it started and where I am now. It's literally the blink of an eye. And if it's your passion, you're not wasting your time because you're doing what you love. And all of this training is building to your career. And actually, my residency was some of the most fun time of my life as well, even as grueling and hard and difficult as it was and challenging. It is also fun. There's a lot of camaraderie with your fellow residents, and you form friendships that last a lifetime. And it's just a great time to be learning everything you're learning. It's just all good. Okay. So let's get to a day in my life, what that actually looks like. And we'll chat about that. So we'll do some consults. First case here that I have for you is a clinic consult. So and this is a real case, a real patient that I saw, a 69-year-old male veteran with history of diabetes type 2 and hypertension, is found to have an incidental hyperkalemia on labs drawn by the primary care physician. And this was on December 6th. with a potassium level of 6.2, then a repeat potassium level of 5.4 then the following day. And then January 3rd, potassium of 5.2, and then a 5.6 on February 7th, 1 month later. So there's a trend here, right? Prior to the recent labs, the potassium had been around in the 5 range. The patient had no complaints. Renal function had been mildly fluctuating with a baseline glomerular filtration rate, which is an estimate of kidney function in the 50 to 60 range. A normal being greater than 90 to 100, depending on age. There is a decline in age. Kidney ultrasound was unremarkable with no obstruction. And when we say no obstruction, we're typically talking about hydronephrosis or urine backflows into the kidney. Medications that the patient was on include 3 medications for diabetes, which are glipizide, metformin, and pioglitazone. Metoprolol, which is a blood pressure medicine, omeprazole, which is for heartburn, and then levothyroxine for hypothyroidism. The patient had poor diabetes control with the hemoglobin A1C level of 9.6. We shoot for under 7 is the goal for most patients. And then the blood pressure was somewhat above goal as well, in the 130s to 150s range. And depending on the patient and the age, but usually our goal is less than 130. The patient was started on a low potassium diet and a medication called furosemide, which is a loop diuretic. It works on the kidneys to lose potassium in the urine. And this was started in February by his primary care physician and then referred to nephrology to myself. And this is the trend of the labs with the most recent one at the office visit right here in front of you on July 20th. And then backwards, you can kind of see the trend of where the potassium level was. And then the creatinine is what we look at for kidney function. And that gets plugged into an equation where, which gives us the GFR, which is, we can kind of think of it and explain it to patients and lay people as like a percentage. We say, oh, your kidney functions at 60%, even though it's not a percentage. It's sometimes easier to understand it that way. So we see the GFR was around 60, which is technically, you know, stage 2 kidney disease, stage 2 kidney disease. But yeah, he dipped a couple of times a little lower, but mostly around 60. So stage 2 kidney disease, which is a mild stage. The rest of the additional workup done was normal, didn't find anything there. And so what, just off the top of your head, and just feel free to guess at this, you're not a nephrologist yet, what is the most likely cause of his hyperkalemia? Hyperkalemia meaning high potassium level. Do we have a poll for this one?
In the chat.
In the chat, okay. See here. Okay, we're getting B. Okay. Mostly B. Okay, high dietary potassium intake. Okay, very interesting. Okay, and then 1A. Okay. Anybody have any other thoughts? Okay, getting mostly A and B. Okay. All right, great. That gives us a lot to talk about. And what is D? Pseudo hyperkalemia. Good question, because I'm going to tell you about that. Okay, great. So the answer is D. And don't worry, you guys, it's just for fun. I don't expect you to know this at all. Okay. This is, you know, these are questions that I was giving to residents. So don't worry, it's just to bring the discussion forward. So pseudo hyperkalemia. So it was pseudo hyperkalemia. Pseudo meaning, you know, it's not really high potassium. How do we figure that out? Well, additional history was obtained during the consultation. So I happen to have a medical student rotating with me. I worked for the VA for a couple of years. I had a medical student with me who was a good history taker. And history is really important in, you know, what I think of as sort of the detective work part that we do as a nephrologist. You kind of sometimes have to really do a lot of digging and figuring out those puzzles, right? So the student went and kind of talked to the patient for a little bit and got this history that he was a construction worker of some type. I'm not sure what his trade was, but he had a traumatic injury years prior to his right arm, where this large marble slab he was carrying fell on his arm, sliced it open right at his anterior elbow, in the area of the cephalic vein, which is where blood is typically drawn. And so he pointed out to the student, you know, here's the vein, and to myself, this is the vein where they love to draw my blood, and I don't know what's going on, why my potassium keeps coming back high. And as you can see, the veins there, hopefully, you know, there's not a normal, there's an altered anatomy going on. And so the patient was sent for a plasma potassium level, and the plasma potassium level was normal. So mystery solved. And I'll explain why in the short time that we have, without going into all of potassium homeostasis. This is part of the nephron here. We have the tubules. I don't know if any of you are learning physiology now. You probably are. You might already know some of this, but this is just an overall picture of potassium homeostasis, which is a pretty complex part of the kidney, but just still a fascinating part, where potassium is reabsorbed and secreted. Oh, good, it's on somebody's exam, according to how much we intake. And so I think some of you had thought that maybe he was taking in too much potassium, but the good news is your kidney is so smart that whatever you intake, it's going to excrete any of the excess, and pretty much everything you take in your daily potassium intake is excreted. The only time that people get high potassium from intake, from dietary intake, is when they have kidney failure. Now you could say, oh, well, he had some kidney disease, but the GFR was too high for that to be the reason. And so we usually don't see problems with potassium until the GFR is lower. Usually it has to go down to about 30. And so one of the issues with kidney disease is you don't really need a lot to live. You know, you can actually have no symptoms until you get down to stage 4 kidney disease, and 5 even sometimes. So we really don't see the issues, unfortunately or fortunately, we don't see them until it's really late in the course of the disease. So someone with stage 2 or 3 kidney disease has typically minimal symptoms and not really a lot of potassium issues. Kidneys are still able to excrete that potassium. So that we kind of ruled that out because his kidney function was too good to be having that high of potassium levels. 90% of potassium excretion out of the body comes from the urine, and 10% from the stool. So the gut does do part of the potassium homeostasis, but kidneys are mostly responsible. And then the potassium levels are maintained in a very narrow range. And so intracellular and extracellular shifts sometimes can play a crucial role there. Aldosterone is the key hormone in regulating potassium in the kidneys, and it modulates excretion. Okay, so pseudohyperkalemia. So what's the pathophys here? Again, some of you may already know this, and so I might be reviewing, but doesn't hurt. So this is typical blood vessel. In the intravascular space, we have 60% plasma and then 40% cells. So you can think of it like 2 compartments almost. And the plasma part is the watery part, where you have the water and the solutes. And then the cellular part is the cells. And what are the cells? Red blood cells, white blood cells, and platelets, right? So in the if we just do a regular serum blood draw, when you do serum, you're getting cells and plasma, right? So when they stuck this patient in the lab and they, you know, got his blood draw, they weren't checking plasma, they were just checking everything. So they got a serum, and what was happening was because of that abnormality, cells were lysing. And when cells lyse, they have potassium in them. Most of the potassium's inside the cell. And so that potassium was leaching out and causing a false hyperkalemia, or falsely elevated potassium. Now, when we do plasma, we are doing a true measurement. So we don't have to worry about the cells. We don't have to worry about them moving. We're just looking at electrolytes and water. And so we can get a real value that we can depend on. So that was how we kind of cracked this case. And I always think of this as being just kind of a really neat case where we kind of had to do a little detective work. But luckily, we were able to figure this out because there could be harm done to the patient if we're trying to lower his potassium, right? And it's not high and we're lowering it, then he could have a low level and that could cause harm. Plus he was being told to restrict it in his diet, and potassium, most of the foods that have potassium are actually pretty healthy foods that people should be not restricting unless they have kidney failure. And then also he was given medications as well that have side effects. So really important to get the right diagnosis and really kind of look through and piece it all together. So it was a good case. Just another couple little points on pseudo hyperkalemia. So the forearm contraction is one way. Fist clenching, overly, clenching the fist, or tourniquets overly tight can also lyse the cells. Hemolysis. And then sometimes we'll see it with like leukemias or patients that have really, really high platelet counts in certain cancers. So severely high, if you just have so many cells, those cells can lyse and we can get a pseudo hyperkalemia. So prevention is key. We actually had them go start drawing his blood on the other arm. You can draw it in a heparinized tube to prevent clotting if clotting is the issue, and just gentle without a tourniquet sometimes can be enough to help. Okay, so the second case that I have for you guys here is a 40-year-old man who undergoes a thyroidectomy for papillary thyroid cancer, and the tumor is removed without complication and surgery is uneventful. But while in recovery, several hours later, he complains of a tingling in his lips and then a cramping in his hands. And hopefully everyone can see the video here of what was going on here with this patient. And they're gonna tap on his face. Can everyone see? Hopefully there's a twitching going on there. Okay. So the labs are drawn and show a serum calcium of 5.6 with an albumin of 2.8. Any ideas what is the diagnosis? And I'm assuming we're just going to use the chat. So
yes, thank you.
Okay. And no pressure, guys. Again, I give these questions to residents and students. So bonus points if anyone knows this. Okay, great. We're seeing some B's. D, B's. Okay, a lot of B's, it looks like. Great job. Okay, wonderful. Yeah, it's hypoparathyroidism. So if some of you are in anatomy or have taken anatomy, the parathyroid glands sit right next to the thyroid glands and are often, it's hard to really not remove them sometimes during surgery. And so this patient's parathyroid was removed during the thyroid cancer surgery. And so he has hypocalcemia, which is low calcium levels. Now, there are two clinical signs for this that we see on exam. The one that I just showed you in the last video was called Shavastic Sign, and that's a momentary contraction of the ipsilateral side of the face. So you kind of tap on the facial nerve at the angle of the jaw like they were doing in the video, and you get a contraction there like you saw, that kind of contraction due to hyperexcitable nerves from the low calcium. And then the other sign I want to show you here is Trousseau's sign, which is a spasm of the hands. Usually we look at the hands, but the feet also could spasm, creating by inflating a blood pressure cuff about 20 millimeters above their patient's blood pressure for a couple of minutes, for 3 minutes typically. And then there's what'll happen is the wrist will flex, and then there's kind of an extension and adduction of the fingers. And this is more specific for tetany. So for the hypocalcemia associated with tetany. And the video here will kind of show you, whoops, oh, sorry about that. We'll show you some physicians doing this in the ER, actually, it looks like on this patient. This is an online video, but I think it's a really nice exam where you can really see it. And these are clinical clues, you know, if we're not sure or you don't have labs back, what's going on. The Trousseau sign here is very specific for tetany. So you should be giving this patient calcium right away, immediately, urgently, and through IV.
Can't move them at all. So his hand is rock solid. Yeah.
So hopefully everybody can see that well. It's very interesting if you ever get a chance to see this on a patient. Okay, so another poll question here. Which of the following electrolyte abnormalities is a complication of kidney failure? And go ahead and put it in the chat. Okay, I'm seeing A and B. A.
Majority A.
B, a lot of A and B. And mostly A and B, but I got 1 or 2 C and D. Okay. A. Okay, interesting. Well, I think you guys remembered potassium because we were talking about it, but it's actually phosphorus that's going to be high. Potassium will be high, not low. So remember, kidneys excrete that potassium normally. If you have kidney failure, these things build up: potassium, phosphorus. Magnesium can build up too, less of an issue, but potassium and phosphorus are the main ones that we deal with kidney failure. And then calcium is actually low. We won't get into why. It's a very complex, but the patients do get mineral bone disease associated with the kidney disease. But potassium and phosphorus are high, and mag is high as well. Okay, so the last consult I have for you guys here is a hospital consult, and this is a fairly recent one over the last year. There was a 56-year-old man with hyperlipidemia and a diagnosis of having a COVID-19 infection the week prior, who was admitted for vomiting, abdominal pain, and acute kidney injury. He had been seen in the ER 3 days prior for fever and cough. And then the ER labs at that time, 3 days ago, revealed a serum creatinine of 1.47. And remember, we use creatinine for kidney function. And so that is a little bit elevated, but not too much. CT of the abdomen and pelvis was done in the ER and did not show any obstruction into the kidneys, no fluid or anything like that. Looking back on his chart, the labs done earlier in the year showed a baseline creatinine of 1.1 and a urine albumin of 44, which is just a little bit elevated, really nothing too crazy. And again, the baseline creatinine of 1.1 really is not too far off from normal values between 0.6 or 7 to 1.1 or so, depending on the lab. So maybe a little tiny bit, but nothing too remarkable. When he was admitted to the hospital, his serum creatinine was 4.97, so markedly elevated. And the eGFR, which again is that calculation where we use the creatinine and we plug in and we kind of get an estimate. When I talk to patients, I'll say your kidneys are at 15%, even though, like I said, it's not a percent, it's actually a rate of filtration, but gives you a good way of thinking about it. So his eGFR was less than 15, so very, very low. So this is kidney failure at this point. Urinalysis showed 2+ protein and 2 red blood cells. We did a 24-hour urine protein analysis collection, and that showed 15 grams of protein. We call that nephrotic range, nephrotic proteinuria. And so that is a lot. And that's really what that means, is just it's in large amounts, quantity wise. And so the threshold for nephrotic is 3.5, typically 3 to 3.5, depending on what how you're collecting it. So this is a very high amount of protein being leaked out of the kidneys. And that indicates to me as a nephrologist that there's something going on with the glomerulus. So some of you who are in your physiology classes and learning about the kidney, the glomerulus is a very important part. That's where we get the glomerular filtration rate equation. That is from the glomerulus, which filters all the blood in the kidney and also filters larger proteins. And so we shouldn't see protein in the urine per se. So this is an indication that there's a glomerular problem. Workup was done and HIV was checked, hepatitis, lupus testing, other autoimmune testing was all negative. Urine drug screen was negative as well. This is what protein in the urine can look like. It looks like foamy urine. Some patients will even describe it as beer foam. My urine looks like beer foam, so that's an indication, we've got protein in the urine, soapy, foamy kind of looking appearance. The hospital course for this patient is that actually from his COVID infection, he really did not need any oxygen, had no lung issues going on. His respiratory status was stable. He really didn't have much of a cough or anything. He wasn't short of breath. The infection was, seemed to be really not affecting his lungs too much. Blood pressure was a little bit elevated in the 150s over 90s. He did report some nausea over the next several days, some decreased appetite, fatigue and sleepiness. And these are actually some kind of non-specific symptoms of kidney failure that patients can get. They can also get some vomiting too, but not eating well, nausea and sleeping a lot. They just kind of can almost slip into like a coma-like state if the kidney failure is really bad. They just get really sleepy. On exam, there was edema as shown in the image here. And we refer to this as pitting edema. If you've ever heard that term, pitting meaning you put your finger into it and you form a pit. And it kind of sticks there and there's an indentation. So we grade edema based off of that. And this is pretty severe. And it's also very typical when patients have nephrotic range proteinuria or nephrotic syndrome. Sometimes we can call it, depending on the constellation of symptoms, that they do get this pitting edema with it because of all of the loss of proteins, the intravasculature. You've lost so much protein that there's a shift of fluid out of the vasculature and into the tissues. So over the next several days, his kidney function did not improve. And by hospital day 4, his blood urea nitrogen or BUN was 80 and his creatinine was 5.8 with the potassium that wasn't super high, but it was creeping up a little bit, 5.4. And normal is usually 3.5 to 5-ish. So nothing that I would get too, upset about as a nephrologist, but still we're not heading in the direction that we need to be. So just put your nephrology hat on today. And what is the next step in management for this patient? What are you going to do if you're the nephrologist here? Go ahead and put your answer in the chat. And again, no judgments on your answer, just guess, Okay, D, E, okay. E, a lot of E, okay. And 1B, and I think I saw 1D. Okay, great. Wow, you guys are already getting there. Good job. You're thinking like a nephrologist. Awesome. So absolutely, A and B, both. This patient is actually pretty young and he didn't, he wouldn't really be someone we would want to discuss hospice care with because you can still live. It's not necessarily terminal. We have dialysis. Sometimes it's not appropriate if someone's already at the end of life from something else, but it's appropriate. He can go on to dialysis. He can, if this doesn't recover, he can get a kidney transplant at some point. And but that's the treatment part, right? Okay, we're going to treat him with dialysis, but we still want to know why. And that's one of the most important things, going back to that Einstein quote, why? I'm always asking why. In medicine, you always ask why. In life, we always ask why. So please keep that curiosity because We don't want to just be putting band-aids and treating people without knowing what we're treating, especially in my field and my specialty. That's how my brain operates. I always want to know the pathology, the pathophysiology, so we can understand it and individualize it and treat it appropriately. So we might be able to cure his kidney failure depending on what's going on here. So we do a kidney biopsy. And what that does is we take a biopsy of the cortex. So we actually can look at the glomeruli under the microscope, and the pathologist does stains on it. They look at electron microscopy, they look at light microscopy, and they look at immunofluorescence. So if you guys are learning about any of that stuff, you know, this is a whole subspecialty of pathology. And this is what it looks like. So hopefully you've seen some light microscopy in some of your courses. If not, when you see it, you know, you can at least recognize this is the light microscopy specimen from this patient's pathology from his kidney biopsy. And it showed a lesion called focal segmental glomerulosclerosis. Very long name, we say FSGS. And there are several types. Some have a worse prognosis than others. Some are treatable and they can go into remission. We treat them sometimes with steroids or other immunomodulator medications. So just because he had kidney failure doesn't necessarily mean it's irreversible or untreatable. So again, this is why we want to know why, so we can treat what it is. This lesion that he had was called a collapsing variant, and that one is more severe with a worse prognosis, does not respond well. And so what we had presumed and kind of pieced together is that this can sometimes be triggered by an infection, and the COVID-19 infection has shown to trigger an FSGS pathology in the kidney in some patients. So upon further research and putting this all together, we believe his FSGS kidney failure lesion was related to his COVID-19 infection, given the temporality and everything. Some case reports, they've shown viral particles in the electron microscopy. Our pathologist did not see any, and she looked through them and we spoke, and we didn't see any virus in there, but definitely this is the lesion. Focal segmental describes actually the lesion pathology. So it's focal. It's not all over the, you know, the renal cortex. It's not all over, but it is in certain places, and then it's segmental. So it's in certain segments of the glomerulus, and sclerosis just mean like a narrowing. So the glomerulus, I'm going to just touch on briefly a little bit more about that on the next slide and what that is, but basically it's a ball of capillaries, like I said, that filters all of the blood and keeps proteins in. So can think of it that way. Unfortunately, this patient did not respond to treatment, and 10 months later, he remained on hemodialysis without recovery, and is hoping for a kidney transplant. Just a little overview here. Definitely don't have time to get into everything about the nephron. It's complex and intricate and wonderful. So much here, but that's just fascinating. But what I wanted to show you was the normal light microscopy here. And so the nephron is the main unit in the kidney and the renal cortex that and the medulla that we look at. When we biopsy, though, we're really just biopsying up here in the cortex, because we want to look at the glomerulus. So the main point of a kidney biopsy is to look at the glomerulus, and you can look at the tubules as well, but we're looking normally for glomerular diseases, and there's multiple different diseases we just don't have time to get into, but you can see here that this is kind of the normal versus the sclerotic appearance on the last slide. And so these are just capillaries, and there should be some space in between there. And if you see on the last one, some of these areas were just really what this is just kind of a scarring up and a loss of the normal spaces that we have. So just a very, very brief overview there. And that's it for my cases. So I I just want to finish with a little bit of advice and tips that I thought of as I was putting this together, that kind of looking back and what would I, recommend in hindsight. And I think one of the biggest lessons for me is to just don't listen to anyone who says you cannot. You can do anything you set your mind to. You can be a French major and still go to medical school. If you have another interest, embrace that, be well-rounded, be multidimensional. And I know this has changed a lot, which is for the better. But when I was in med school, it was that you had to do biology, or not in med school, sorry, in pre-med, in undergrad, you had to do you had to be a biology major, and that was it. And there weren't other options, or you shouldn't be doing it. And that was the message. And I think this has changed a lot, but I want to reinforce that really, the more well-rounded you are as an individual, I think that actually the better off you are. You relate to patients in different ways. You're human, and also you are not just living in this one-dimensional world of medicine. You have other interests, and so it's all for the good. Work hard and play hard. I will say, I still I studied a lot, but I also had fun too, and I took opportunities to travel and do different things. And I probably didn't have as high of a GPA as I could have if I had just put my head down and studied. But what I did was, that year when I had my pre-med prerequisites, all my science classes that I kind of packed a lot of them in after I got my degree, I made sure I excelled in all of those. And so I excelled there where I needed to. And it's all about balance, I guess. And then volunteering, I think, is really important. Even if it's maybe not your passion, I still think it makes you a better person, and it makes you relate to people who may not be as fortunate. You really get a sense of gratitude, and it, we're here on this earth to help each other, right? So it's just it's going to be part of your career, is helping others. So I think volunteering in whatever way you can, there's so many ways to do it, but be true to yourself. Don't force like I said, don't force yourself to be a science major if that's not your thing. You don't have to be. Be true to who you are, and do what you love, and you'll find your way there. Know your strengths and weaknesses, and play to your strengths. And one of my biggest things was that I had a lot of service work and volunteering, and I had a personal statement that was compelling because of the accident that I went through and my experience with that. My MCAT scores, I believe, were average. I mean, I definitely wasn't, in the very top, but I don't think that is necessary to be an excellent physician. I work with a lot of brilliant people, and it doesn't always translate to being the most brilliant doctor. So just those are my tips. Those are my personal tips. And I think there's a couple questions building in the chat, but I'm going to just hold them for 1 second because this is the last slide. And I just want to leave you guys with this thought question, then we can chat more. But I wanted to kind of hear your guys' thoughts on what is the recipe for a great physician, and I'll put mine up here as well. But I'm sure that you've interacted with physicians, and think about that too as you go into this field. How were you treated, and how would you want to be treated, and how would you want your family to be treated? That's my approach, because I've been on both ends of it, and I've had family members get sick, and even as a physician, I felt very helpless in speaking even to other people who are technically my colleagues. When you're on the other side of it and people blow you off or brush you off, it's not a good feeling. Even if you're not really ill, validate people's concerns. They come in and you think, well, this isn't an emergency, you're fine, but it still could be very upsetting to them. So I always validate patients' concerns. I'm seeing compassion and passion and intelligence. Yes. I mean, first and foremost, you have to have the medical knowledge. So, I mean, that's just basic, right? And then we move it beyond that. And then there's all these other nuances, but medical knowledge, you have to be willing to learn the rest of your life. You don't stop. It doesn't end at medical school or residency. You're constantly learning. Empathy, yes. Yes, empathy is huge. You got to be able to put yourself in someone else's shoes and understand, but also being honest. I don't sugarcoat things for my patients. Sometimes I give them what they can handle and we get our way there, but I don't, I try to smooth it over or try to make it sound better. You know, that doesn't help anybody. Being clear is being kind. If you're uncomfortable with it, then you need to get comfortable with having these conversations. You know, it's life and it's death, and you know, there's illness, and it's hard. Some of these conversations we have to have, but the best approach is honest. And when you don't know, don't try to make something up. People can tell, and you're not going to know everything. You have to sometimes look things up, or you consult someone, or you know, I think that's a great physician when you know your limitations, and you admit when you're wrong. Oh, you know, we could have done this a little better. And be interested in and invested in the outcome, and aware of your own biases, and self-reflect on that, and just always try to be better. I'm seeing some really great stuff. Adaptive to change, be aware of the patient's perspective. Yes. And transparency. Yeah, you guys are on it. So those are my thoughts, but I'd love to hear yours. And this is concludes my presentation part. And so now hopefully we have some time to chat. And I think there was a question here. Someone had asked.
Yeah. So Melissa asked, did you consider other fellowships, or did you always want to do nephrology?
Oh, okay. Yeah, that's a great question. Melissa, yeah, I actually did not know I wanted to do nephrology until kind of late. It was actually the end of my residency. Originally, and this is sometimes like life takes you where you're supposed to go, because originally I wanted to do GI, gastroenterology. And even when I was a medical student, I think I wanted to do surgery because I just thought it was so fascinating and cool. But now I realize there's really a difference in personality there that wouldn't have fit as well, because that is more procedures, you know, doing scopes, and, you know, somebody's bleeding and you do a scope, and it's, you don't have all the problem solving. And I just get so much more out of my specialty. I think it fits with my personality that I get to really sit and like think through things and figure them out, and look through data, and, you know, crunch numbers and look at trends and graphs and all that nerdy stuff that I love to do. So I think I did not. And you know, you can change. It happens. It's hard to know. It's really hard to know until you're doing it. And I did a nephrology rotation late in my residency. And that's when I started changing my mind. And I thought, you know, maybe I should look at this, and this might fit. And once I did the rotation is when I kind of realized. So, you know, it's okay to not know what you want to do, and you'll figure it out. And sometimes life will just push you that way. So, it ended up that I kind of made that decision a little bit later. And
yeah, I agree. Everything happens for a reason.
Yeah.
So another question we have is, did you have a time where you used osteopathic technique in nephrology to help someone? The student finds the distinction between osteopathic and allopathic medicine super fascinating.
Yeah, that's a great question. You know, I wish I could say that I still use it in nephrology. I don't use it in nephrology per se. I use the mindset that I was taught, which was looking at the person as a whole and not just looking at an organ system. And I think we forget that. A lot of physicians forget that. And you know, you just like, this is my organ and I'm just dealing with the kidney. No. We're looking at a person here. So I'm always treating the person. And sometimes that takes me a little away, I'm looking at other things. It's not really the kidneys per se, but we're not in, our organs aren't in silos. Our organs are all connected. So, we're all intertwined. And when we treat the person, you're going to get much better results than just treating a disease. And I think that's one of the key points that I was really, harped on in DO school versus allopathic. Although I think that the allopathic field has moved in that direction, as we've all kind of moved a little bit in that direction. And but I do put my hands on patients in a healing way. I sometimes use something called Reiki, if anyone knows about that. So I trained and did some Reiki courses, and sometimes I'll use just a healing hand kind of feeling thing. And patients love that. So I found that they love that, healing touch and feeling that you're giving them some positive energy, and that goes a long way. So, but I do sometimes use my osteopathic skills. I have to say I'm more on like family members, because a lot of it is musculoskeletal, although there is some stuff that's organ, a lot of it is musculoskeletal. So it just doesn't always come into play, but great question.
Thank you. So another student would like to know, do you use your OMM skills as a nephrologist?
I think I just answered that one pretty much. I kind of, yeah, not as a nephrologist as much. Yeah.
Alrighty. So we have another question. How do you support a patient medically and personally in end-stage renal failure if they choose to refuse dialysis?
That's a good one, Victoria. This is interesting. I don't know if you've seen that or you work at all with kidney patients, because that's a really insightful question. But yeah, that does happen. A lot of the times it's when patients are stage 5 and they're like on the cliff of needing dialysis, and it's like, no. And then usually what'll happen is, unfortunately, they will, really feel bad enough that they're like, okay, I'll do dialysis. Now there's another side where some patients are just, I'm not going to do it. I don't care how bad I feel, or I'm not going to live my life on a machine. And, I can say that I actually get that, why someone would think that. And if they are making that conscious decision, I don't feel that I am here to judge anyone. So if that's their life and their path, I'm with you on this path, is what I tell my patients. Like, we're not here to tell people, you should be doing this. I mean, we're here to align with what are their goals in life. And if your goal is to not live your life on a machine and it's not acceptable to you, then, okay, then let's talk about how we can, make your life comfortable or meet your goals, which is, whatever it is they want to do with their life. And so sometimes we'll consult hospice. I have had some patients choose to forego dialysis if they were in kidney failure, and they have passed away, from their kidney failure rather than going through dialysis. And if you know anything about dialysis, you'll understand why someone would not want to do it, because it's not fun. It's no way to live. It really deteriorates your life quality. That being said, a lot of people are just fine doing it, and they can sit on a machine for 4 hours and read or watch TV and zone out, and it doesn't bother them. So to each their own is my opinion on that one. And I'm here on the path to help them in what their goals are, not to tell them what their goals are. You can't tell people that. You can give them options, and you can talk through them, and you can make recommendations, but that's kind of my approach to that.
So thank you for that answer. Are there any other specialties that you refer to often to help with your nephrology specialty?
Yeah. So yeah, Rosalind, we work closely with urologists, and for anyone who doesn't know, urologists are kind of like the surgeons of the kidney. Some people will call them like the plumbers. So they do all of the surgical management. So people who have kidney stones or obstructions anywhere along the genitourinary tract, we work closely with them on those patients who have kidney issues in that respect. We also end up working really closely with cardiologists because kidney failure and heart failure, unfortunately, they come together a lot, and the kidneys affect the heart, and then the heart affects the kidneys. So sometimes they kind of battle it out, but we do see a lot of that. Those two organs can often fail together. And so we work closely with cardiologists a lot as well. And I would say those are the two top ones, but sometimes rheumatology, I refer sometimes because there are some autoimmune diseases that can cause glomerular diseases, like that patient that I presented at the last case that we were kind of investigating. Sometimes we'll find lupus in the kidney, and we work with rheumatologists. We'll have to refer for that, and other kind of autoimmune diseases. So I would say those are the main three specialties that we work with. But yeah, being a nephrologist, we do overlap with a lot of other specialties. And so again, that's why it's good to be a good internist, because you kind of have to know about other fields and other organ systems.
Thank you. So Winnie would like to know, as a nephrologist, do you participate in the kidney transplant surgery or only at the post-surgery of the transplant?
Yeah, that's a great question. So we actually do not do any of the surgical procedures, but we do the post, that, as you're kind of hinting at, the post-op care of the transplant patient, and all of the immunosuppression is done by the nephrologist. And there's actually a subspecialty called transplant nephrology. So after you do general nephrology, you can opt to do an additional 1-year fellowship in transplant. And then you can be a transplant nephrologist, where you work with a team consisting of surgeons and the transplant nephrologist, who manages all of the post-operative care and the immunosuppression.
Thank you. So since we are coming to an end, would you like to close off with any words before I do the wrap-up presentation?
I think I said it all in the presentation, but I want to wish everybody luck in your careers in the future and your path, and just enjoy it. And please feel free to reach out to me with any questions. If I can help in any way, I'm always happy to do that. Very excited for the future of medicine, and I have a lot of hope in your guys' generation, because I know you're very forward thinking, and we're going to continue to improve and make medicine better. So welcome to the field, you guys.
Thank you. So I'm going to start the wrap-up presentation now. Okay. Sorry. There we go. Sorry about that, guys. Alrighty, so thank you so much for the informative presentation. I think we all enjoyed learning a lot from our wonderful speaker. Considering this, we would like to encourage you all, everyone, to reflect on this session today. What brought you to the session today? Oops. And what are 3 major takeaways you got? What do you want to learn more about? This writing or reflection is not required. However, we do encourage you to submit it to our website for publication and for recognition on your hard work to enhance future applications. If you would like to learn more about pre-op shadowing and get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. We are also accepting team member applications if you would like to take a more active role in PHS to lead projects and initiatives to be up here with us. So once again, we are humbly asking that if you are financially able to donate, that you please consider sending a few dollars to us via Venmo or PayPal. It costs a lot to keep our program up and running and free for you all. So if you know someone who can afford it, or you can, please support us. And if you know someone that can donate, please send the link that's in the chat. Sorry about that. And now for the part you are all here for and waiting for, earning a digital certificate for the virtual shadowing hours from this session today. First, go to our website and find our professionals course pages. Next, you can take the quick 10-question multiple choice quiz based on the content from the session today. You will have 30 minutes per attempt to earn 70% or higher to get a certificate. We know that sometimes technology can be difficult, And for this reason, you have 2 attempts to take the assessment, and if you run into any difficulties, please contact us. To ensure that our website does not crash from a high influx of students, we recommend waiting 30 minutes to an hour after this session to take the quiz, which will be open indefinitely. Lastly, once you've passed your exam, you can click the Finish Course button at the bottom of the Professionals page and download your virtual certificate for your virtual shadowing hours. If you missed a part of the session or want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the Professionals pages on our website. Take the post-shadowing assessment quizzes as well. Be sure to follow us on social media and enroll in our email list for the latest updates and upcoming sessions and events. We are currently booked every weekday through June for virtual shadowing hours, so I hope to see you guys there. Be sure to follow, Thank you for joining us today, and please stick around if you have any other questions. Myself and my other team members will be happy to answer them. And this shadowing session is officially over, and I invite you all to log off and have a wonderful day. Thank you, guys.